First thing we need to do is review and approve the minutes from our February meeting. So has everyone had a chance to review them, and would anybody like to approve?
I'll motion to approve.
All right, and do we have a second?
I think I saw Clayton say something, but he's muted.
Yeah, I'll second.
All right, thanks, Clayton. And all in approval?
Aye.
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 And any opposed? And I don't believe we have any abstain. Or do we have any abstain? All right, then we'll go ahead and move forward then. Brian, did we have any housekeeping you needed to discuss?
Just that at the next meeting, we'll need to nominate the chair. Whether it's you continuing or someone else, just something to have on the radar for our next meeting in September.
All right, yeah. People can get their applications into me. I think we'll have a love to pass that along if that's appropriate, but we'll go ahead and wait till then. All right, thank you so much. And our DUR board update.
Thank you. So over the last few months, the DUR board have met to discuss and approve the continuous glucose monitoring prior authorization, the VERQUVO prior authorization, and roxadustat prior authorization. The board will meet again in June to discuss about the Gvoke, Zegalogue, PA, and the Utah Medicaid vaccination effort. That's all. Thanks.
Very good. Thank you very much. And we'll go ahead and move on to our Accountable Care Organization update, reporting on the methodologies for the PDL. Looks like first we have Melina, we have Shea Wilson, or Heidi Goodrick.
Hi, this is Heidi Goodrich. I'll be presenting today.
We're having some trouble hearing you. I heard a little bit of something, but I wasn't able to hear sufficient to understand. If that's correct, Heidi, do you want to say something in the chat? There we go. Thank you.
Should we do just jump over to Matt Mitchell first, and then from Select Health, and then go back to Heidi if she's able to connect?
Yeah, why don't we do that?
Good morning, Matt Mitchell. Can you hear me?
Yes, thank you.
Great. So Matt Mitchell, Executive Director for Select Health Pharmacy Services. Real quick, Select Health is a non-for-profit organization that's part of Intermountain Healthcare, which is an IDN. We work together to share clinical integration, clinical programs, and patient initiatives. These programs and initiatives provide patients high-quality care, as well as demonstrate our commitment to the community and help people live healthy lives. In addition to collaboration and working with collaboration, Select Health and Intermountain have developed, implemented different clinical programs. We call them care process models. Examples include things like asthma, diabetes, hypertension, acute coronary syndrome, oncology, pain, rheumatology, and IBD. And we have clinical pharmacists that sit on all of those clinical programs within Intermountain. We have our own P&T committee, has practicing physicians and pharmacists from different specialties, as well as primary care. Their knowledge and experience contribute to how our P&T committee understands clinical rationale for recommendations, decisions, as well as review trends and costs. We cover the PDL Plus from the state. All new drugs approved by the FDA come within the P&T committee. within 90 days. The majority are reviewed within 30 to 60 days. And we look at efficacy, safety, including clinical trials, pivotal trials, clinical guidelines, expert opinion, safety, different considerations like dosage form, special handling, DURs, etc. The decisions are based on the P&T committee, including PA step therapy, quantity limit restrictions, as well as tiering placement. And each category is reviewed at least annually, and it's all the major categories as well as minor categories. Any questions?
Not that I can think of.
Okay.
Just quickly, Matt, this is Joe Busby with the state. I know I could probably get this off the website, but could you please just give us a brief summary of where you're at with the Hep C treatments as an organization?
Yeah, Hep C. Sure. So we've aligned with the state. I think the other ACOs have aligned as well, going down to all genotypes. So it's really pretty open. It's a diagnosis. It's in consultation with a GI specialist. And so it's pretty open. And we should be in line with the criteria with the state from several years ago.
Thank you.
Absolutely. Thanks, Joe.
All right. Thank you, Matt.
Sure.
And if we don't have any other questions, we'll, Heidi, are we anywhere?
Can you guys hear me now?
Yes.
Okay, sorry, it seemed to be a problem with my headset.
No problem. Thank you.
Okay, first let me just give you a little bit of information about Molina Healthcare. Molina Healthcare is a Fortune 500 company. We manage healthcare services under the Medicaid and Medicare programs and through the state insurance marketplaces. We cover 4.4 million lives across 18 states. We have a National Pharmacy and Therapeutics Committee. It acts as our clinical governing body for all drug-related activities across the enterprise. Our voting membership are external members that are not employed by Molina, but within our networks. It's comprised of 11 members with a mixture of clinicians of both pharmacists and physicians with a mixture of specialties and a variety of backgrounds. This committee meets a minimum of quarterly, and they report into our National Quality Improvement Committee. There are a few other subcommittees that feed into the National P&T Committee. This includes a Molina Policy Voting Committee that has state representation of the pre-P&T activities, our DUR board, which reviews utilization across the enterprise, and then a PA Core Committee, which annually reviews and updates our drug criteria. Some responsibilities of our P&T Committee is they review and approve utilization management, which utilization controls include PA step therapy, quantity limits, generic substitutions, quality monitoring indicators, and our DUR program and board oversight. They also evaluate our policies and procedures and help educate our providers on drug products usage and P&T committee decisions. Our preferred drug list covers many different drugs to treat a wide variety of diseases and medical conditions. Our preferred drug list has 2 tiers or levels of covered drugs. Oh, looks like you have the slides up. I'm on slide 4 right now. There we go. Thank you. So our tier 1 includes our preferred generic drugs, and then tier 2 includes our preferred brand drugs, including specialty drugs. We use a variety of utilization controls that is indicated on our published formulary, which includes step therapy, age and quantity limits, prior authorization, generic drugs with therapeutic equivalents to the brand name drug, and opioid edits that follows the state Medicaid morphine milligram equivalent, or MME daily limits. Next slide, please. Our preferred drug list basis for coverage. First, it needs to be a covered benefit per Utah Medicaid and CMS rules. It needs to follow FDA-approved indication and dosage limits. Safety and reported adverse events. Quality. The treatment must be supported by national guidelines for practice standards accepted by the medical community. Efficacy. Formulary drugs must show proven and comparable efficacy to non-formulary drugs. We also evaluate drug utilization trends of clinically similar medications. We closely monitor the brand and generic pipeline. We also look at the drug's economic value. We evaluate the net cost and market share. We also take into consideration the Medicaid drug rebate program. And most definitely, we evaluate the potential impact these decisions have on our members. And that's my presentation today. Are there any questions? All right, thank you.
Thank you so much, Heidi. I think we've all kind of felt that that stress of being in a meeting and not having our technology working for us. So I'm glad you're able to get it up quickly.
Glad I'm not alone in that. Thanks.
Oh yeah, absolutely. Next we have Leslie Rodriguez with Healthy Choice. And I don't see the name on the list, so maybe we're... All right. Put a note down on that one. And Laura Britton from Healthy You.
Hello, can you hear me?
Yes.
Great. Do you have my slides or no?
They're on their way.
Great, thank you. I know I turned them in last minute. Well, good morning, everyone. Thank you for allowing us at Healthy You to come present our formulary methodology again this year. Next slide, please. So our formulary design is, as the other ACOs, is based on the Medicaid fee-for-service preferred drug list, the structure, the therapeutic categories. I did want to mention that an analysis done by the ACOs over the last year has shown that our alignment is about 74% in the same coverage as the state. The drugs on our formulary are either preferred or not preferred, carved out or not covered by fee-for-service Medicaid. Next slide, please. So we review, and apologies for the typo there, we review new drugs, dosage forms, and indications weekly. We've recently formed a joint venture, PBM, not preferred drug list, PBM. And so we've got everything in-house, and this makes it completely transparent and really gives us more control over what is on our preferred drug list. These recommendations made at these weekly meetings are compiled and presented to the University of Utah Health Plan's Pharmacy and Therapeutics Committee on a quarterly basis. We do regularly consult the state preferred drug list PDL Plus file and our contract with the state before making coverage recommendations. Next slide, please. As I said, the inclusion is determined by the P&T committee. It's comprised by primary and specialty physicians, outside primary care and specialty physicians, as well as pharmacists. I've already talked about quarterly. The P&T committee is responsible for developing, managing, updating, and administering the formulary. Next slide, please. The formulary determinations are based on the most current clinical trials, treatment guidelines, pharmacoeconomic studies, FDA-approved prescribing information, safety data, utilization data, and other outcomes data. Clinical trials and guidelines are considered when they are evidence-based, peer-reviewed, and relevant to clinical practice. Pharmacoeconomics data includes total cost of care, including drug costs, administration fees, and other healthcare expenditures. And the committee also considers the therapeutic advantages in terms of efficacy and safety in determining addition to formulary. Next slide, please. The P&T committee makes a reasonable effort to review new FDA-approved drugs within 90 days of release to market, and the committee will make a decision on each new FDA-approved drug within 180 days of its release, or a clinical justification will be provided if this timeframe is not met. Each therapeutic class is also updated yearly, reviewed and updated yearly. Next slide, please. As I mentioned, when we meet weekly to review the formulary, it is dynamic and continuously revised. It's posted real time on our website whenever changes are made, and any negative changes to the formulary are communicated to the affected members as per the designated contractual timeframe. Any significant changes to the formulary are communicated to providers through our provider newsletter. Next slide. Drug utilization processes and protocols are administered by our Drug Utilization Review Board, and all activities of the DUR board are reported up and approved by the P&T committee. These items include edits such as prior authorization, step therapy, quantity limits, and the DUR board also is responsible to draft medication use policies, or RPA criteria, which are then reviewed and approved by the P&T committee. Next slide. These medication use policies are based on medical necessity, evidence-based medicine, and pharmacoeconomics again. The prior authorization requirements are posted online. And as an integrated healthcare system, we regularly consult subject matter experts from the university before, during, and after the P&T process to ensure that our criteria and coverage determinations do not conflict with current prescribing practices. Next slide. There again is a prior authorization process for certain high-risk, high-dollar medications as well as non-preferred drugs. All Medicaid-covered medications are accessible to members through the process, and there is a formal appeals process in place for members or providers who do not agree with our coverage determination. And our formulary is in compliance with ACA Section 1557 regarding prohibition of discrimination based on those components listed on the slide. Next slide. And that's my presentation. Are there any questions? Hearing none, thank you very much.
All right, thank you, Laura. Oh. All right. We'll go ahead and jump into our glucagon presentation by Elena, and then go from there.
Okay, thank you. Good morning. Let me share with you the slides I prepared. Okay, let's see.
Before we jump into the glucagon presentation, could we check again to see if Health Choice is here to present? We missed theirs. Leslie Rodriguez. Okay.
All right, thanks, Brian.
Yep. Thank you. Go ahead, Elena.
Okay. Okay, so can you all see the slides?
Yes, thank you.
Okay, perfect. So I'm going to present the drug class review of glucagon products for the treatment of severe hypoglycemia. Severe hypoglycemia is an abnormal fall in blood glucose concentration that alters cognitive, and/or physical functioning and requires assistance from another person to recover. Immediate recovery is paramount as severe hypoglycemia can result in unconsciousness and death. Hypoglycemia typically occurs in patients with diabetes who are receiving insulin therapy, but may occur with other anti-hyperglycemic agents such as sulfonylureas. Guidelines recommend use of oral glucose or glucagon for the treatment of hypoglycemia, depending on the severity of symptoms and/or blood glucose level. In the ambulatory setting, patients will require glucagon for the management of hypoglycemia if they are unwilling or unable to swallow a fast-acting glucose source or if unresponsive. The 2021 American Diabetes Association, or ADA, guideline recommends, based on expert consensus or clinical experience, prescribing glucagon for patients at high risk of level 2 hypoglycemia, that is blood glucose level less than 54 milligrams per deciliter, or level 3 hypoglycemia, defined as a severe episode characterized by impaired mental and/or physical status that requires support from another person. In addition to healthcare professionals, other individuals such as caregivers, school personnel, or family members may administer glucagon. They should be trained on how and when glucagon should be administered and where the glucagon product is located. In 2015, the American Association of Clinical Endocrinologists and American College of Endocrinologists strongly recommended the administration of intramuscular or subcutaneous glucagon by a trained individual for hypoglycemia recovery if the patient is unresponsive or unable to swallow rapidly absorbable glucose. This table displays the glucagon products currently approved for the treatment of severe hypoglycemia in adult and pediatric patients with diabetes. These include glucagon powder for reconstitution to a subcutaneous intramuscular or intravenous solution, glucagon nasal powder, glucagon in a ready-to-use subcutaneous solution, and dasiglucagon in a ready-to-use subcutaneous solution. On the right column, you can see the brand names or generic availability for each preparation. The 2021 ADA guideline does not prefer one glucagon product over another. Glucagon products increase blood glucose by stimulating hepatic glucagon receptors that activate the signaling pathway for the breakdown of the hepatic glycogen into glucose. In severe hypoglycemia, a single dose of a glucagon product should be administered, followed by a call for emergency assistance. If there is no response after 15 minutes, another single dose may be administered. And when the patient responds to treatment, oral carbohydrates should be given. This table shows some characteristics of the glucagon preparations. Powder for injectable solution preparations require multi-step reconstitution and injection procedures, which may be challenging and confusing for untrained caregivers during emergency situations. Glucagon and dasiglucagon subcutaneous solution are ready-to-use solutions that do not require reconstitution. Glucagon nasal powder is a ready-to-use needle-free formulation that does not require reconstitution or patient inhalation. Traditional products containing glucagon powder for injectable solution are available as a kit with a vial of glucagon powder and a syringe of sterile water for reconstitution, whereas the ready-to-use glucagon preparations are available as single-dose auto-injectors, prefilled syringes, or intranasal devices. These ready-to-use rescue treatments constitute a major improvement in an emergency setting as the administration process is simplified, accelerated, and can help avoid confusion and medication errors. Following a systematic searching of it, Medline and Embase for direct evidence, 2 systematic reviews, 2 additional head-to-head randomized controlled trials, and 2 simulation studies comparing intranasal glucagon versus glucagon powder for intramuscular subcutaneous solution were identified. Most of the studies included patients with type 1 diabetes on insulin therapy. Evidence showed a comparable efficacy between intranasal glucagon and glucagon powder for reconstitution in terms of blood glucose increase for reversing insulin-induced hypoglycemia in pediatric and adult patients with diabetes. The mean time to treatment success was reported to be significantly longer with intranasal glucagon versus glucagon powder for intramuscular solution by 1 to 4 minutes, depending on the trial. However, the time for preparing the glucagon dose was not considered. Some limitations of the evidence were that hypoglycemia was induced through intravenous administration of insulin, and trials were not designed to evaluate recovery from severe hypoglycemia due to ethical concerns. 2 randomized controlled trials suggested similar efficacy at resolving insulin-induced hypoglycemia between dasiglucagon and glucagon powder for subcutaneous solution in adult and pediatric patients with type 1 diabetes. However, formal statistical analysis for this comparison are lacking. 2 simulation studies that compared usability of 2 glucagon products suggested a higher rate of successful administration and shorter time to complete administration with intranasal glucagon compared to glucagon powder for intramuscular solution. Regarding safety, nausea and vomiting are well-known and frequent adverse events associated with use of all glucagon formulations. Injectable glucagon is associated with injection site pain and irritation. Nasal adverse events such as nasal congestion and ocular adverse events such as increased lacrimation were more commonly reported with intranasal glucagon compared to glucagon powder for reconstitution. Warnings related to glucagon products include a significant blood pressure increase in patients with pheochromocytoma, hypoglycemia in patients with insulinoma, allergic reactions including anaphylactic shock, and lack of efficacy in patients with inadequate levels of hepatic glycogen. For the purposes of the Utah Medicaid preferred drug list, all glucagon products are considered equally efficacious at increasing plasma glucose in adults and pediatric patients with hypoglycemia. Safety profiles of glucagon products appear to be similar, except for administration route specific adverse effects. We suggest considering including at least 1 ready-to-use formulation as preferred in the PDL. Access to a particular non-preferred product could be accommodated via a prior authorization that describes medical necessities such as age appropriateness or administration issues with a preferred agent. And regarding utilization, among the Utah Medicaid fee-for-service pharmacy claims during 2020, 123 unique patients utilized a glucagon product, 60 were pediatric patients. Utilization in the overall population was highest for glucagon emergency kit for low blood sugar, powder for injectable solution, followed by Baqsimi nasal powder and glucagon hypokit powder for injectable solution. Thank you. This is all I have.
Thanks, Elena. I've got a question. On slide 9, you talked about simulation studies, and I'm not familiar with them. So could you maybe provide some background on what a simulation study is?
Yeah, I mean, in these studies, they were administering glucagon to mannequin, so it was a simulated administration of glucagon. It's
Looking
not,
at the time from when someone exhibits symptoms until when the drug is administered. Is that what they were trying to simulate?
it's more they were trying to see if the caregivers or users were able to administer glucagon properly, doing the reconstitution properly, reconstitution of glucagon powder plus the water for injection. So they were more trying to see if these products are easy to administer, if there were medication errors in the administration. So this is what they were trying to see in the inoculation study.
Okay.
Or the easy of use. Yeah.
And were there any studies like that comparing one ready-to-use formulation with another ready-to-use formulation?
No. Yeah, no. There were only studies of IN, I think intranasal glucagon versus glucagon powder for reconstitution. So we didn't see any ready-to-use versus ready-to-use.
Okay, thank you.
Yeah.
Elena, was there anything talking about like the expiration of these products? Like, I know lots of times we administer or we dispense them and they have like a 1-year expiration or something. Is there anything that talks about how post-dated that expiration date is?
I mean, there should be information in the packaging, sir. I think I was including in the main table that I have in table 1. It was including more information about storage information, but not about the expiration date. I'm not sure if there's. In the packages, we probably have that information. It's true that I have some information for some of them. Some of them should be stored up to 24 months. For example, the glucagon powder for reconstitution. It should be up to 24 months. With the nasal powder, I don't have that information here, but and the new product, Zegalog, dasiglucagon, should be could be at room temperature for up to 12 months. Yeah.
Okay, thank you. All right. We'll go ahead and move on to public comment. We do have a couple late additions that we'll add to those, but we'll start with Tim Hampton from Zealand Pharma. And these are limited to 3 minutes. let's see, I'm not.
Perhaps Tim's having some technical difficulties. Let's move on to the next person and maybe we can circle back to Tim.
Yeah. All right. So we'll go with Elizabeth Lubelchik. And I apologize if I destroyed the name.
Good morning. This is Elizabeth. Can you hear me?
Yes.
Okay, great. Okay, so good morning. My name is Elizabeth Lebelzik. I'm an evidence and outcomes liaison with Eli Lilly and Company, and I'll be providing testimony on nasal glucagon, brand name Baqsimi, today. Baqsimi is an anti-hypoglycemic agent indicated for the treatment of severe hypoglycemia in patients with diabetes ages 4 years of age and older. Severe hypoglycemia is a medical emergency for people with type 1 and type 2 diabetes and is characterized by altered cognitive or physical functioning that requires assistance from another person for recovery. If untreated, severe hypoglycemia can lead to serious consequences such as loss of consciousness, seizure, coma, and death. Baqsimi is an innovative product designed with severe hypoglycemia rescue in mind. It is compact, portable, and ready to use for nasal administration with no reconstitution required. The Baqsimi device contains a single dose of 3 milligrams of nasal glucagon powder. After administration, the nasal powder is passively absorbed and the dose does not need to be inhaled. EMS should be called after dose administration, and oral carbohydrates should be administered once the patient responds to treatment. Baqsimi has been studied in adults and children ages 4 and above with type 1 diabetes and a small subset of adult patients with type 2 diabetes. 2 studies conducted in adults demonstrated non-inferiority to 1 milligrams of intramuscular glucagon in adult patients. The pediatric pharmacokinetic and pharmacodynamic study demonstrated similar glucose responses to nasal glucagon and intramuscular glucagon. A simulated rescue study was conducted to determine how trained caregivers or untrained acquaintances would administer nasal and injectable glucagon to mannequins, simulating unconscious people with diabetes in a severe hypoglycemic episode. Approximately 90% of trained and untrained participants were able to administer Baqsimi successfully. For intramuscular glucagon, 16% of the trained caregivers and 0% of the untrained acquaintances were able to successfully administer intramuscular glucagon. The median time to successful administration in the nasal glucagon group was 30 seconds, compared to 73 seconds for intramuscular glucagon in trained users. The most common adverse reactions in adults are nausea, headache, vomiting, and upper respiratory tract irritation. Please refer to the Baqsimi prescribing information for full details and safety information. A preliminary analysis done prior to auto-injector approval has shown that more patients, caregivers, and acquaintances preferred Baqsimi to an auto-injector, noting its ease of use. Thank you for the opportunity to address the committee this morning, and I'd be happy to take any questions.
Thank you very much. Did we have any questions?
Pardon the interruption. This is Tim Hampton from Zealand Pharma. For some reason, I was unable to. It looked like the system actually had me muted on your end, and so I was unable to speak. So I went ahead and hung up and called in. If I am still able to present, I would appreciate it.
Yeah, this is just fine.
Yeah, go ahead.
Okay, yeah, thank you so much. So like I said, my name is Tim Hampton, and I am with Global Medical Affairs at Zealand Pharma, and appreciate the opportunity to provide the requested information in support of adding Zegalogue as unrestricted to the Utah Medicaid preferred drug list. Zegalogue is indicated for the treatment of severe hypoglycemia in pediatric and adult patients with diabetes age 6 years and above. And I refer you to the full Zegalogue prescribing information for complete warnings, precautions, adverse reactions, and that can be found at zegalogue.com. Zegalogue is a first-in-class glucagon analog with improved aqueous solubility compared to native human glucagon and is available in an auto-injector and pre-filled syringe that does not require reconstitution prior to administration. Zegalogue has a 3-year expiration from the date of manufacture and may be stored in refrigeration for that entire duration. But once removed from refrigeration, Zegalogue may then be stored at room temperature for 12 months, unless, of course, it expires before then. In each of the 3 pivotal phase 3 trials, 2 adult and 1 pediatric. The primary endpoint was time to plasma glucose recovery, defined as an increase in blood glucose of greater than or equal to 20 milligrams per deciliter from the time of administration. Zegalogue met all primary and secondary endpoints and demonstrated a median time to plasma glucose recovery of 10 minutes in adult and pediatric subjects alike. Within the first 15 minutes post-dose, up to 99% of adults and 95% of pediatrics had already been recovered. Adverse events were similar in occurrence and frequency to other injectable glucagon products, including nausea, vomiting, headache, diarrhea in adults, and injection site pain. Budget impact modeling demonstrated that Zegalogue may have a favorable budget impact for U.S. payers due to its rate of successful administration and percentage of patients achieving recovery. In a population of 1 million covered lives with an occurrence of approximately 12,000 severe hypoglycemic events per year, treatment with Zegalogue was estimated to provide a total cost savings of 62% compared to glucagon rescue products that require multiple steps for reconstitution prior to injection. Reconstitution of glucagon rescue kits has been shown to result in a 34% probability of successful dose administration. Treatment with Zegalogue was estimated to provide a total cost savings of 20% when compared to Gvoke. Results from a pivotal phase 3 trial showed that Gvoke had a mean time to plasma glucose recovery of 13.8 minutes, with 78.9% of adult patients achieving recovery in the first 15 minutes after injection. In conclusion, Zegalogue demonstrated a time to plasma glucose recovery of 10 minutes, with 99% of adults and 95% of pediatrics rescued within 15 minutes. I respectfully request that Zegalogue be added to the preferred drug list as unrestricted for the Medicaid beneficiaries of Utah. Thanks again for the opportunity to share the information, and I too would be happy to answer any questions when it's appropriate.
Thank you very much, Tim. And if we don't have any questions, then we have Jennifer Draney from Utah Insulin for All.
Thank you. Can you see me or hear me?
Yes.
Okay, awesome. Okay, so if you don't know me, so I advocate for diabetics, right? On the side, like completely separate from the chapter and being a type 1 diabetic myself and my son being a type 1 diabetic, I also redistribute insulin. We call it diabetic Christmas or the life market because it's not a black market. It's not selling, it's always giving. It's actually giving life to others, right? Because we're in an insulin crisis right now and people can't afford their medications. So people that have unused, they've switched their prescriptions, or people that have died, I end up picking up their unused insulin and supplies and I give it to people that are rationing, right? Glucagon is the second thing requested. Glucagon saves lives. You can be cruising along all day long with great blood sugar levels and literally in your sleep, just drop for no reason at all. And having that emergency glucagon right there is the difference between life and death and an ambulance coming and going to the hospital and paying for the ambulance ride, right? It is shoving honey down your son's throat and holding him because he's shaking so hard, seizing, to try to keep him alive and to keep his levels up. It's literally everything to have this medication on hand as a diabetic and an insulin dependent. The pens are hard to use. You have to pull down the pants, you have to mix the solution, and you have to stab it in the thigh. But I'd rather have that than honey or frosting or something else. It costs anywhere up to $500 if you don't have great insurance to pay for it. And I've tried to fill it and they go, well, you have Medicaid, so we can't use the coupon. So this is my exchange box out here, this cooler. People come pick it up right here. They come drop off what they don't need right in this little box right here in my cooler. And in here today is a couple pens of Humalog, some Baselinger, and an expired glucagon pen. So you can use them expired. I'd rather not give one expired, but this girl doesn't have anything. She's pregnant and she's waiting her up to 6 weeks to get approved for Medicaid, which she won't get one of these anyway. And she's type 1. So I'm giving her insulin and one of these to have on hand. So I hope that you guys take into consideration that this is a real life and death situation and we need to have this.
Thank you. Our time's up, Ms. Straney. Thank you for the comments, so thank you.
We did want to, you mentioned that you had some knowledge of the stability of the different products in comparison to each other. Could you just share what you know about that briefly?
So they do work expired. When you pick one up, you're lucky to get one that has a 12-month expiration date. I guess they sit on the pharmacy shelves for about 24 months. So that's what I know about the pens when you pick one up, the needles. The inhaling powder, I've actually never seen one. I mean, they're so far like sparse to actually see one. I just know that the difference in administration is vast, and the capability of being able to give somebody nasal powder versus pulling down their pants, mixing. I can show you what it looks like. The powder in solution is pretty big deal. And for a kid, this is hard to do. You have to open this, and there's the powder, and then the solution's in there, and you stick the needle in the top and you shake it and twirl it around, and you pull it down in there and you shake it up, and then you pull the syringe back, and that takes a few minutes, and the person's already dropping and possibly seizing at that point. So the nasal powder obviously would be fantastic to have. But shoot, we'll take these. I mean, we'll take to have these on hand, you know, would be so nice.
And just with knowledge of the auto injectors like the Gvoke or the Zegalogue?
Those are a little bit easier to use than this. I have seen them before. I've never used one. So they are a little bit easier.
I was thinking more in terms of the stability of the product and shelf life.
The shelf life, like the farmer rep mentioned before, there's a couple of them that will last 3 years. So some of them do last a little bit longer, but that's all. I've never had one. So I guess mine was just the difference on, you know, accessibility, and usually get one when you pick one up. That's about 12 months for expiration.
Thank you.
Thank you so much, Jennifer. We can see your passion, so I appreciate that.
Yeah, thanks.
So we'll go ahead and move on to some committee discussion or any other questions that we may have. So I'll go ahead and open the floor on that to the committee members.
You know, with some of the new additions to the market in this class, it's some exciting opportunities, and we would like the feedback from the committee on how best to approach this with regard to potential management on the preferred drug list. So I welcome everybody's feedback.
I mean, it seems like from the information that we've heard, the efficacy when administered seems to be similar, you know, within you know, minutes between all the different products. The biggest thing that I'm kind of interested in or trying to wrap my head around is, you know, how easily is it prepared, and then subsequently administered, and if there's any training if you can't get it in, it's not going to be effective. And so just kind of weighing those things to add to the similar safety and efficacy of the products. Anybody else?
Sure. I mean, I think it's pretty clear that we definitely want to have at least one agent that is, ready to use. I think that's pretty obvious that we need to make sure that's available. I guess the question that we have here is, are we wanting to approve more than one of such agents, the powder as well as the ready to go injectable? I mean, people are familiar with the injectable, but the powder seems like it's a good alternative. In terms of efficacy, it looks like there's reasonable data there. So I don't think it would be unreasonable to at least recommend both to the DUR committee for consideration. Just because there are a couple alternatives there to choose from.
Okay. So a couple of the points that I think I've heard is that, one, the efficacy is similar across the group, is what I understand, and that perhaps we want at least one ready-to-use product. Not to say that we can't also have, the powder for reconstitution or more than one, but that was kind of what I seem to get. Would anyone like to formulate into a motion?
I'd like to make a motion first that each of these agents is, fairly equally safe and efficacious. And secondly, that the preferred drug list should include at least one ready-to-use glucagon product.
I'll second that motion.
All right, and all in. Well, can we take out the word may? Is that appropriate to do, that they may be similar and efficacious, or should we just say that they are? Or how does that formally, is there any issue with that?
I would say they are similarly efficacious, and as far as safety, there is, differences between the nasal powder and the injectable glucagon, but otherwise, in the review, there was really not a, huge difference in terms of more serious adverse effects.
Sure. No, I completely agree with the motions, and I just want to make sure that the phrasing was how we usually do it. I'm not sure. So
I'll leave that to Brian to.
That's my goal too. But all in favor of the first motion, which is that all the products are both safe, equally safe and efficacious. All in agreement. Say aye.
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 And any opposed? All right, and then the second being that we include one ready-to-use formulation to be included on the PDL. All in favor?
Aye.
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 And
I'm
any
sorry,
opposed?
Okay,
Oh,
was
sorry,
that
go ahead.
at least one, did you say? I'm sorry.
Yes, at least
Or at
one.
least- Oh, perfect. Thank you, Michelle, for that.
Aye.
Yeah, so at least one. Aye.
Aye.
And any opposed on that one? Okay, perfect. Is there any other discussion that needs to be had on that, or that we didn't address?
For me, I just want to make sure that we're recommending consideration for multiple formulation options, would be just the other.
Yeah, I mean, that's certainly on the table.
Yeah.
And we'll look at our options, but you know, the motion is to have at least one ready to use.
And that's sort of why I worded it that way, so that there's at least one, but can be more than one, depending on, you know, how the, you know, Department of Health determines that, because that's more of a black box for me, so.
Exactly. All right. Thank you.
Well, before we close the meeting, it looks like Leslie has joined the meeting. And if we want to return to Health Choice for presentation.
Oh, wonderful. That'd be great.
So Leslie Rodriguez, if you can present your PDL methodology, that'd be great.
The Health Choice P&T committee is a committee that's comprised of multidisciplinary licensed professionals. The committee meets quarterly, and the committee is combined. It's a combination of health plan employees and practicing physicians with no affiliation with the health plan. And each quarter, the committee is committed to reviewing all new chemical entities, all new indications, no later than 180 days after the chemical entity hits the market or the new indication is known. The committee is responsible for evaluating not only placement of drugs on the formulary, but also revising or creating new prior auth drug criteria. Does anyone have any questions about our Health Choice P&T committee? All right, thank you.
All right. Brian, anything else you think we need to go over today before we go ahead and adjourn?
Not that I can think of. I will remind attendees that before we allow public comment, we do require a conflict of interest statement. I saw there was a note in the chat, and you know, that's kind of a public comment, and each of the people who did give public comment did submit a conflict of interest statement. I don't have one on file for the person who made the statement in the chat, and so that's why we're not having more discussion on that topic.
Okay, thank you. All right, so looks like our next meeting is going to be in September. We're going to be reviewing the wakefulness promoting agents, and I look forward to doing that. But for now, we'll go ahead and adjourn this meeting. I'll go ahead and move to adjourn.
Second.
And all in favor?
Aye.
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 All right, any opposed? Very good, guys. Thank you so much, and we'll see you again in September.
All right. Thanks.
Thank you.
Thank you. Bye-bye.
Thanks.
Bye.